Today, we're going to learn ECG from absolute basics. If you've always found ECG confusing, this video will make it simple. By the end of this lesson, you'll understand what an ECG records, how the electrical impulse travels through the heart, what each wave represents, how ECG paper works, normal ECG values, lead localization, coronary artery correlation, cardiac axis, and the J point. Let's start with the most basic question. What is an ECG? ECG stands for electrocardiogram. It is a recording of the electrical activity of the heart. Remember, an ECG records electrical activity, not the mechanical pumping of the heart. Electrical activation occurs first, and mechanical contraction follows. Now let's understand how this electrical impulse travels. The impulse begins in the sinoatrial node, or SA node, which is the natural pacemaker of the heart. From the SA node, the impulse spreads through both atria, causing atrial depolarization. It then reaches the atrioventricular node, or AV node, where there is a brief physiological delay. This delay allows the ventricles enough time to fill with blood before they contract. After the AV node, the impulse travels through the bundle of His, divides into the right and left bundle branches, and finally reaches the Purkinje fibres. Purkinje fibres conduct electrical impulses at the fastest velocity, producing rapid and coordinated ventricular contraction. Now let's understand the ECG waves. The P wave represents atrial depolarization. Whenever you see a P wave, think of electrical activation of the atria. Next is the PR interval. It represents the time taken for the electrical impulse to travel from the atria to the ventricles through the AV node. Most of this interval reflects the AV nodal delay. The QRS complex represents ventricular depolarization. Since the ventricles contain much more muscle than the atria, the QRS complex is much larger than the P wave. Under normal conditions, ventricular depolarization is very rapid, so the QRS complex remains narrow. The T wave represents ventricular repolarization. A simple way to remember this is P equals atrial depolarization, QRS equals ventricular depolarization, T equals ventricular repolarization. Now let's understand ECG paper. Each small square horizontally represents 0.04 seconds. 5 small squares make one large square, which equals 0.20 seconds. Vertically, each small square represents 0.1 millivolt. Understanding these measurements helps you calculate heart rate, intervals, and wave amplitudes accurately. Now let's look at the normal ECG values. The normal PR interval is 0.12 to 0.20 seconds, or 3 to 5 small boxes. The normal QRS duration is less than 0.12 seconds, usually 2 to 3 small boxes. The QT interval is approximately 0.40 seconds, which corresponds to about 10 to 12 small boxes. Now let's learn which ECG leads look at different parts of the heart. Among the precordial leads, V1 and V2 look at the septal wall. V3 and V4 look at the anterior wall, while V5 and V6 look at the lateral wall. Among the limb leads, lead 1 and AVL represent the lateral wall. Lead 2, lead 3, and AVF represent the inferior wall. Lead AVR mainly looks toward the right side of the heart. Let's also revise the chest lead positions. V1 is placed in the 4th intercostal space at the right sternal border. V2 is placed in the 4th intercostal space at the left sternal border. V3 is placed midway between V2 and V4. V4 is placed in the 5th intercostal space at the midclavicular line. V5 is placed at the anterior axillary line. V6 is placed at the mid-axillary line. Now let's understand the cardiac axis. Lead 1 lies at 0 degrees. Lead 2 lies at plus 60 degrees. Lead 3 lies at plus 120 degrees. AVF lies at plus 90 degrees. AVL lies at minus 30 degrees. AVR lies at minus 150 degrees. These angles represent the orientation of the limb leads and help us determine the electrical axis of the heart. Next is coronary artery correlation. The anterior wall is mainly supplied by the left anterior descending artery, or LAD. The septal wall is also supplied by the LAD. The lateral wall is mainly supplied by the left circumflex artery, or LCX. The inferior wall is usually supplied by the right coronary artery, or RCA. This relationship is extremely useful when interpreting myocardial infarction on an ECG. Finally, let's understand the J point. The J point is the point where the QRS complex ends and the ST segment begins. In conditions such as acute ST elevation myocardial infarction, elevation of the J point produces ST segment elevation on the ECG. A simple rule to remember is lead tells you the wall tells you the artery tells you the diagnosis. Congratulations! You now understand the basic principles of ECG interpretation. In the next video, we'll learn how to calculate heart rate, identify cardiac rhythm, determine the electrical axis, recognize bundle branch blocks, and follow a step-by-step approach to interpreting any ECG confidently. If you found this video helpful, please like, share, and subscribe to the channel. For more anesthesia, critical care, and ECG content, follow @Anesthesia Talk on Instagram.